for Pratiksha Academic. Welcome everyone. Today's topic is Phagosurgery and overview. The speaker is Dr. Priyam Sharma. She is CNT consultant Nightingale Hospital and visiting consultant at Pratiksha Hospital. Her special interest in swallowing disorder. And the moderator of the session is Dr. Mahamaya Prasad Singh. He is senior head and neck surgeon, primarily practicing at Northeast Cancer Hospital and Research Center, Guwahati. And he has done MBBS and MS ENT from Guwahati Medical College. And he has done MCH in head and neck oncology and reconstructive surgery from Amrita Institute of Medical Science. Over to you, Dr. Mahamaya.
Thank you, ma'am. And thank you for having me here for this upcoming subspecialty of head and neck surgery, which is known as phagosurgery. I still don't know whether this term has been incorporated into the study, but still preliminary it is known as this phagosurgery, which includes surgery relating to swallowing disorders. So regarding this, we also don't have much knowledge, but we all are practicing and learning on a day-to-day basis, and also from our cases. So Dr. Priyam, please start your talk and enlighten us with this new subspecialty. Thank you.
Yes, Dr. Mahamaya. So I will start with the presentation now. I hope the first slide is visible.
Yes.
Yes.
Okay. So good evening, everyone. Thank you so much for being with us on the Pratiksha Academic Forum. At the very onset, I would like to thank the team of Pratiksha, especially Dr. Anjana, for being so consistent with us and following up with us for newer topics every month. So as Dr. Mahamaya said, phagosurgery is not exactly a typical book term right now. It was first suggested by Dr. Jayakumar Menon to give a meaning to all the surgeries going to be performed for improving the swallowing of the patient. It's better to put them in one umbrella term called phagosurgery. So today's topic will be about the surgeries which we are going to do for swallowing patients and just an overview of those. So let's start. First of all, these surgeries are not used as a first-line treatment for the patients. Usually the patient who are failing with the conservative treatment that we give, whether it is therapy, whether it is medical management, only those patients are going to be put for surgical treatment. So there are some temporary measures we can take before going for direct surgery. We can give the patient relief by tracheostomy. We can give parenteral feeding. We can give feeding by gastrostomy. Now, broadly, the phagosurgical procedures can be clubbed into two categories. So as we all know, swallowing is not just the act of taking food. It is also the act of protecting our airway while we are taking food. So the surgeries can be designed either to protect the airway while we are taking food, that is to reinforce the airway safety, and also the surgeries which can ease the bolus transit of the food itself. So we'll start with the most common procedure that is being performed of all. It was initially started as a phonosurgical procedure to improve the voice, but it has also found to be very useful in giving the patient better swallowing to minimize aspiration or penetration for the patient. So we start with the laryngeal framework surgery. It helps in closure of the laryngeal wall. So in which patients we are going to do? The patients where the hemilarynx is not functioning. That is, one of the vocal cord is not closing properly when we are swallowing. It may be either due to iatrogenic cause, it may be because of radiotherapy, post-surgery, post-trauma, or in fact, sometimes even idiopathic vocal nerve palsy, vocal cord palsy. So what we have in this procedure is injection laryngoplasty and medialation laryngoplasty with silastic sheet. So we start with the injection laryngoplasty, the most basic procedure. It was first described by Brunings in 1911, where he performed this procedure with paraffin injection. So now we have progressed much farther with better alternatives like Teflon, hyaluronic acid, autologous fat from patient, carboxymethylcellulose, and calcium hydroxyapatite. Of this, hyaluronic acid is giving very good result. Even dermatologists are using it as the dermal fillers available in the market as Zuvederm. And if the patient party is a bit financially preoccupied, we can go for autologous fat, gives equally good result. And the only problem with injection laryngoplasty is it's a temporary measure. It's not going to solve the problem forever, but it gives a good result, cost effective for the patient, and it does not require GA in most cases. So the routes we use are, we can use transnasally, it can be given to fiber optic laryngoscope, transorally it can be given, and also percutaneous with direct vision from flexible scope. So what are the pitfalls? The injection is non-reversible. So once you inject, you cannot take back the amount. So you have to be very diligent while delivering the product. It does not close the posterior glottic cap. So if the vocal cord is in a cadaveric position with arytenoid laterally rotated, it's not going to close the posterior glottic cap. Now, also granuloma is usually seen with Teflon injection, not so much with the fat and hyaluronic acid. So we'll just have a look at the video once. This is a patient with left vocal cord palsy. The fat is injected just into the paraglottic space anterior to the vocal process of the arytenoid. A bit of over injection is desired because some of the fat is going to be resorbed over a period of time. So a bit of over injection crossing the midline is preferred. So we come to the medialization thyroplasty procedure with silastic implant described by Ishiki. It involves implanting silastic implant lateral to vocal cord to medialize. So in this procedure, you can see this is the left vocal cord, which is paralyzed, and this is the paraglottic space. We are trying to put a silastic implant sheet into the paraglottic space to give a pressure on the left vocal cord to medialize it. Usually this process is performed under local anesthesia, and the patient's vocal cord movement is monitored using a flexible laryngoscope. So this is a video I got from YouTube from Dr. Nupur Nerurkar. We'll have a look. This is a skin incision on the neck. We expose the thyroid cartilage, and then we try to make a window on the thyroid cartilage. Perichondrium is inside and a flap is created. And then the depth of the window is measured, so the implant can be carved out according to our expectations. So this is a gauge to measure the depth. The implant is then carved up from a silastic block. And then the implant is placed into the thyroid window, thyroid cartilage window. And the final position is assessed. The patient is asked to phonate, and whether the voice improvement is good or not, we can measure at the end of the surgery. So some of the pitfalls that we may encounter during this procedure is perforation of the laryngeal ventricle. So if we are not very careful enough while carving out the cartilage, we may injure the laryngeal ventricle, which can result in implant infection later on. Injury to superior laryngeal vessels may be there. Transient stridor and over medialization. So because we are using a bigger implant than required, it can cause this, but it is easily reversible. We can take out the implant and recarve it. Contraindications, these are relative contraindications. There may be scarring from laryngeal radiation or trauma, which causes a bit of immobility in the larynx, and prior Teflon injection. So we come to the next procedure, which is performed under phagosurgery, is cricopharyngeal myotomy. So what do we know about cricopharynx? This is the narrowest part of the GI tract, just proximal to the opening of esophagus. So this is composed of the inferior constrictor muscle, that is the cricopharyngeus muscle, and also the circular muscle of esophagus. So we can see this is the cricopharyngeus, and this is the area of cricopharyngeal sphincter. So what are the causes of dysfunction? Most commonly, we have reflux. We have post-radiation spasm of the cricopharynx, and we have any neurological conditions like stroke, amyotrophic lateral sclerosis, Parkinson's disease. So these all cause the cricopharyngeal muscle to go into a spasm-like state, and it does not allow the bolus of food to pass into the lower esophagus. So how do we diagnose it? In MBS, that is modified barium swallow, see, there is a huge buildup of residue in the pyriform sinuses and the hypopharynx, and there is a vertical bar at the level of cricopharynx, allowing very little of the dye to go into the esophagus. With FEES, we can expect this picture, big residue piling up in both the pyriform sinuses and the retroarytenoid region. So what are the temporary measures we can do before going to the surgery proper? We can go for botulinum toxin injection. Again, it requires repeated injections over a regular interval of time, but gives very good results. And dilatation using Maloney Burgess. So what are the techniques of myotomy? In earlier days, transcervical method was used. I did not find any image or video reference, so I'll go with the theoretical part only. So basically, it's like when we do the thyroid surgery, we expose the larynx, and the larynx should be rotated anteriorly. And then the cervical esophagus will also be pulled. We should take care not to injure the recurrent or the superior laryngeal nerve in this process. And then the cricopharyngeal muscle is identified like a fan-like appearance in the posterior aspect of the esophagus. And then the entire muscle along the entire length is divided, and mucosa should be left intact. So the possible complications in this surgery is if we injure the mucosa, we are going to cause an esophageal injury. And of course, recurrent and superior laryngeal nerve injury are there. So nowadays, a more refined approach is used with the endoscopic approach. So suspension endoscope, as we use in VLS, is used. In this case, we are using either an esophagoscope or a hypopharyngoscope. Most of the cases these days are done with the assistance of laser. So as we can see in the video, so the cricopharynx, this is a mound of tissue. Anytime it's contracted, it's identified just proximal to the esophageal opening. And after we identified it, laser beam, as you can see, is used to dissect the muscle in the entire length, starting from the midline. The dissection is continued until we reach the region of buccopharyngeal fascia. So the difference between transcervical and endoscopic is that transcervical preserves the mucosa, and endoscopic, it preserves the buccopharyngeal fascia. So the definite advantages that we have is the laser's accuracy. The injury to the nerves is not possible in this method, and also reduced risk to surrounding structures. We come to the palatal adhesion or pharyngeal flap surgery. So in which patients we are going to do this with unilateral palatal paralysis. It can be due to congenital causes, it can be due to acquired neurological causes as well. So obviously the patient must have undergone some medical therapy, and after that only, when they have not shown any improvement, they are put up for this surgery. So the relative contraindications are if the patients are having severe untreated obstructive sleep apnea, because this surgery is going to make sleep apnea worse. So we have to be keeping that in mind. So the technique is a transoral route. The mouth is kept open by a mouth retractor, and this soft palate incision is given extending into the posterior fossils. So as you can see, this is in front view. From the sagittal view, if you can see, the posterior fascial pillars, the posterior palate pillars are then sutured to the posterior pharyngeal wall, creating an adhesion on the nasopharynx on one particular side. So the final product looks like this. This is the preoperative picture. This is a 70-degree scope view from the nose down the throat. So we can see this is the soft palate. And if the adhesion is created between this part and this part, the final picture looks like this. So the nasal regurgitation that is happening stops from that affected side. So what are the pitfalls? If we are performing the surgery too soon in a patient, especially with neurological disorder, the patient who may earlier recover with therapies, we should not directly jump off to the surgery in the first line. Closure of nasopharynx across midline if we are going past the uvula, and failure to adequately suture palate to the posterior pharyngeal wall. The complications we may encounter in the breakdown of adhesion. Palatal fistula, if we are not very diligent with the suturing method, we can create an additional problem for the patient and decreased nasal airflow. Now we come to a subject which is very commonly done, glossectomy. So when we resect up to 1/3 of the tongue, it can easily heal by itself and there is not much impairment of the movement as well. But when more than 1/3 of tongue has to be resected, then the need for a flap repair comes around. So what we do, we can go for either pectoralis major myocutaneous flap, or we can go for free flap. So the problem with the PMMC flap is that it's a bit bulkier, so it makes movement more difficult for the patient in the post-operative period. Plus, there is always a pulling down action of the PMMC flap on the tongue. So that's why free flap is more preferred in this kind of patient. The free flap may be the radial forearm flap or anterolateral thigh flap. Okay, so we come to the hyodopexy part. Again, I did not get much photos or videos regarding this. I just got the theoretical part, so I thought I might even share it. So as we all know, hyolaryngeal excursion, the elevation of the larynx is important for the swallowing mechanism to progress. So in some patients, whether it is post-radiation or post-trauma, for some reason, if the hyoid bone is not elevating properly, the larynx will also not elevate, and then swallowing problems will emerge in the patient. So in those patients, we can go for hyolaryngeal excursion, also known as hyodopexy. So what we do, we pass some non-absorbable sutures through the hyoid, and we anchor these with screws to the mandible, as you can see in the picture. And this helps the hyoid bone to do the hyolaryngeal excursion and help with the swallowing, the pharyngeal phase of the swallowing of the patient. Now we come to some unmanageable cases like bilateral laryngeal incompetence. So sometimes if the patient has gone total thyroidectomy, very rare to occur, but it has occurred in some patients. There may be bilateral vocal cord palsy, bilateral adductor palsy. We are talking about that. So this causes intractable aspiration for the patient. So most of the patient, they can be managed with the use of cuff tracheostomy tube. But then there are some patients who are unable to manage even the salivary aspirations. So what we can do in this patient, we can do the epiglottic oversew. That is, we sew the epiglottis over the arytenoids, leaving the PFS free and then creating a stoma of the tracheostomy from outside. Then there is this laryngotracheal separation method, as you can see. So there are two methods of doing laryngotracheal separation. In one method, this trachea is taken out as a tracheostomy stoma, and the blind end of the subglottis is sutured onto the proximal esophagus. So whatever liquid the patient is aspirating, it can go directly to the esophagus. And there is a second method where the subglottis is just kept as a blunt pouch. It does not connect to anything. And the trachea is taken out as a stoma on the external skin. And for those patients, sometimes in the earlier times, laryngectomy used to be done in the patients where nothing else was feasible. There are some also other surgeries which can be clubbed under phagosurgery because they are obviously helping with the swallowing. So if the patient is having bigger osteophyte that is obstructing the bolus transit, so we can give osteophyte surgery, Zenker's diverticulum surgery, release of esophageal and pharyngeal stricture, and of course, even Nissan's fundoplication for hiatus hernia. It can be taken up, but because these are not exactly under the purview of ENT, I'm going to skip them. So with this, I would like to come to the end of my slide. It was not an exhaustive list, but we are trying to learn with each passing day. It's a very new surgery and new subject for all of us. And we try to learn newer things every day. I would like to hear some suggestions from our esteemed delegates present here. Thank you so much.
So thank you, Dr. Priyam, for your basic plus as well as lucid presentation on the various surgeries that are being performed for the under the phagosurgery. So if anybody has any question, it can be directed to Dr. Priyam.
Well, Dr. Priyam,
Yes, sir.
this is Dr. Anupam Hajarkar from Jorhat.
Yes, sir.
Can you give me some insight into the osteophyte surgery?
Routinely, actually, we do not do, I guess, ENT, but the spinal orthopedic surgeons, they do it. Spinal surgeries, I have never come across in my life, but a lot of patients, they do have this problem with osteophyte. Elderly patients, in fact, they constantly have this lump sensation. But personally, I have never come across one myself.
If I
Yeah, just
may
because
sort
I
of, if I may
saw
sort
that
of
thing under your
give
listing,
some.
because recently in last few years of my clinical practice, I have come across around 3 patients with that sensation of lump, and incidentally having gone through a VDL and a subsequent CT, the osteophyte of the anterior osteophytes causing a bulge of the posterior pharyngeal wall along the hypopharynx. That is quite a matter of concern for those people who are suffering from those issues.
Yes.
Is there a center really who is actually doing these things, osteophyte surgery?
Can I come in here at this point?
Yes, Gautam, yes.
I have had experience with a couple of patients who had undergone surgery. I had referred the first patient actually who had undergone osteophyte surgery was Dr. Professor Amrit Borua, our ex-principal of GMCH cardiology. He had a huge osteophyte for which he was aspirating. So Dr. MLA Rahman actually did a transpharyngeal drilling of the osteophyte, the anterior osteophyte. Then there was another one, actually both were done by Dr. Emily Rahman in the Rahman hospital. I had referred both the patients to him because I did not want to personally take the risk of doing it. Maybe we can actually do it because it's not a very dangerous thing if you look at it. But then the spinal cord is also quite nearby. If you have an issue, you can fall into a lot of big trouble.
Because while dealing with foreign bodies by lateral pharyngotomy approach, when the endoscopic approach fails, so if we ENT surgeons are well versed with that lateral pharyngotomy approach for foreign bodies, possibly we can also do osteophyte surgery.
Why not? We can expand our horizons, definitely.
Yeah, actually, yes. I think there's another field where we can get our noses in also. Anupam, I think you're right.
Sir,
I have seen only one case. That was an 80 something plus aged gentleman who came with dysphagia when I was in Biborwa. So we did an endoscopy and didn't find anything, but the scope was, not going in easily into the esophagus. So we did a plain X-ray of the neck, and lo and behold, a huge osteophyte on the anterior aspect of the cervical spine.
Yes.
Then we suggested to him that you can undergo surgery. Of course, we didn't know who was going to do the surgery. Otherwise, we could have done it. But he didn't want it because he could swallow liquids. So I said, no, I'm okay. I don't want to go and undergo any surgery. So I'll take whatever I can. So he was okay. He came back for a checkup after about a month or two, I forget. And he said that I'm okay with whatever little difficulty I'm having. Since it is not cancer, I don't want to undergo any kind of surgery. So
Yes,
that
sir.
is
Many times the people land up because of that fear,
yes,
cancerophobia.
yes. That
Yes.
patient had come to Biburwa to show.
Okay. In fact, sir, the third patient of mine, I met him this morning only.
Okay.
This morning, and I just passed on the counseling message to him that it's not cancer. So long you are not trouble, and this so long if it is not progressive, your dysphagia is not progressive, I think we can wait and pull on. So that's what I just counsel him regarding that. But just having seen this presentation, osteophyte surgery, if there is a center who is doing all these things here in Assam itself, probably we can think of doing so.
Mm. Yes.
And in fact, we can refer also if that person is doing with precision. No harm in referring to such centers.
Mm-hmm. Yeah, like Gautam said that.
Yes, sir. Just to add on, these things, subjects are new to everybody. So, what I feel that to go ahead, we can also have our neurosurgery friends with us while starting these cases. So, and most of the things that now the neurosurgeons, most of them are doing this osteophyte surgeries and spinal surgeries much more efficiently. So we can have their help also along with side and can gradually do 2-3 cases and maybe then carry on to take on ourselves.
Yes, yes, yes. That's very true.
Earlier, orthopedic surgeons used to do also.
Yes, sir. Orthopedics, neurosurgeons,
I think
now
spine
both
surgery.
of them are doing.
Yeah, spine surgery, orthopedics, as well as neuro surgeons are performing.
I think you should take the neurosurgeon. If some complication happens, you should not cross the border. If you cross the border, the complication you will be sued. Because therefore you should take a neurosurgeon rather with this.
I think that's a better idea.
If something happens, they can do anything to you.
Hmm.
So it may be easy for someone, maybe tougher for someone.
Yes.
Thank you. Thank you, sir.
Thank you. Thank you, Anupam, for bringing it up.
Miriam, you
Yes,
have mentioned about medialization laryngoplasty in one presentation and one PPT.
actually thyroplasty, yes.
It should be thyroplasty, not
Yes,
laryngoplasty.
yes,
It's
yes.
wrong actually.
Yes.
Therefore, I want to correct your that presentation, that part.
Yes.
And moreover, you have rightly said, in the morning I posted, I've never heard a surgery called phagosurgery. I thought that it is a phonosurgery. But then again, said, I have it is phagosurgery. But then in the evening, when there is no patient assembly, I go to net. That article by the Jayakumar Menon and Ishak, and also by the Thangapan, and also by Amrita's, there's 4 there's a book, one book is there. I think Mahamaya will
Yes,
know the
yes.
better because that book has mentioned everything about this. And actually, I think it is, this when you do a surgery of your phonosurgery or a sleep surgery, I think it corrects the dysphagia also. As you have shown the unilateral palatal palsy, and your test Vivek shows the jetplasty also, jetaplasty on the time like that, the sutures of the palatopharyngeal muscles. You have nicely shown that. But really it is interesting and very tough, and the patient should, we have actually, I've seen some patients very bad, actually. There should be a good center to give them some relief, starting from the counseling to the proper positional therapy and everything. Because this positional therapy, surgery, and your exercise, everything go hand by hand. Then I think it will be a good result. Thank you, Priyam. Very good, very lucid presentation you have given. And you are giving always a lucid presentation.
Dr. Priyam, there is one question from Pratismita.
Yes.
Good evening, all. I just wanted to know what is the percentage of patients who undergo phago surgery have to also undergo swallowing therapy post surgery?
Yes, since we are not doing a very lot of surgeries, but whatever we have done, almost everyone has to go some kind of therapy. before and after surgery, almost everyone. Otherwise, the surgery doesn't exactly guarantee a success overnight. You will have to work on the muscle functioning even after the surgery. For example, if you are having medialization thyroplasty, the most common surgery that we have done, injection and medialization. So all the patients have required some kind of voice or swallowing therapy after surgery. And it's important to set realistic expectations for the patients also, so that you don't think that just after the day of surgery, you'll be having a good lunch meal and all. You will have some time to work on the consistency of food, on the type of food that you are taking, on the postural modification that we have to give while you're having food. All these things, the expectation setting of the patient, I think, is of paramount importance. Otherwise, you'll have a lot of difficult time in explaining to the patient why you had to do the surgery and what are the outcomes of the surgery.
Just to add on, if there is any complication regarding your dysphagia, so the thing is that first and the foremost step is always your exercises or the maneuvers which we
Yes.
do. If
Yes.
this maneuvers doesn't work out,
Yes.
then only we go for it, because
Yes,
to
then
go for
only.
intervention in this already complicated stage, because
Yes.
Priyam had already most of the things he have mentioned in the neurological dysfunction or the benign cases. But in malignant cases, if they are or they have already undergone a surgery or chemoradiation and
Right.
radiation, so their normal anatomical structures are already deranged, either in the form of surgery or from radiation chemotherapy. So again, to go ahead with the surgery, not contemplating on the preventive mechanisms as well as the other exercises, so the chances of failure increases. So most of the time we need to give a thorough evaluation, and also there are a lot of procedures that can be done, but which procedure will help that patient, that is also need to be ascertained, which can be only done with careful examination with either video fluoroscopy, FEES, whatever maneuver we do. The cause of dysphagia should be ascertained first, and then going ahead contemplating the surgery along with proper discussion with the patient.
Yes.
One thing I wanted to point out in your talk, Priyam,
Yes, sir.
you mentioned about medialization thyroplasty using Teflon sheet, or what was it?
Elastic. In one of the
Elastic sheet.
slides, I mistakenly said it is a sheet. It's a block, actually.
It's a block, actually.
The block, yes.
Because sheet means you'll have to put layer upon layer, several
Yeah.
layers, and they'll start moving.
They have mentioned all, but they have not mentioned Gore-Tex.
Yes. Yes.
Gore-Tex,
Practically, I have not
nowadays-
seen, so I thought because I have
Actually,
little
we have
knowledge
seen in
about
a
that.
Kochi conference long back, coaching the life surgery of Gore-Tex.
Hmm.
Nothing, just introducing the same window and the same thing. But it is not that of good result like a silicon block.
No, actually, Gore-Tex has a lot of extrusion rate. It is very high.
Yes.
So Gore-Tex nowadays, I think very few people use.
But still, it is easy to do and you can adjust accordingly. But
you can.
there is not much literature. But one question I have to ask is a practical question actually. Some people, old fellow actually, little aged, not my age, my age is also, then my below or upper my age. So, there is some dysphagia type, but there is nothing. And many physicians also come to me that when he takes some food, that it goes to larynx. But on examination, there is nothing. It is a laxity of muscle or due to there's something other causes.
When elderly people, there's a
Not
term
much
called
elderly, but younger than me also.
okay. So there is a thing called presbyphagia. So there is a overall muscular atrophy of the patient, plus a bit of neuromuscular incoordination. But on examination, what happens when we are doing FEES or MBS, the amount of food bolus we give is really small. It's less than 5 ml. So the patient usually does not aspirate while he's in the examination room. But when he goes back home, he tries to take from a cup of water and he tries to gulp it down. And then they have the sudden choking episodes. So if you take history very carefully, usually if they are having a lot of food at one time, not minding that they are having small portions, then only they have this problem. But once you ask them to have this just small bites of food, smaller but frequent meals, the problem drastically improves.
Mhm.
Previously,
Any exercise is there?
Yes, 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 yes. See, if the pharyngeal contraction is a bit problematic, if you are seeing some residue in the pyriform sinus, we can give the Masako maneuver. So I'll try to demonstrate it. We just try to lightly bite the tongue between the two incisor teeth, and then the patient is asked to swallow while biting the tongue. It's a bit difficult, but then that is the goal, to make the pharynx contract more.
But I advise the physician,
Yeah.
3 or 4 reasons, to make this where you go into mandir, you know, how that your with a tight balloon or this your honko, you know, the English term
Yes.
I don't know.
Conch
Yes.
shell.
When
Chunk, yes.
it subsides his prayer, increasing the devotion of prayer also, and side by side improving the dysphagia also. It's not bad. I think he has improved
That
for
is
after
actually a
1 month.
palatal exercise, sir.
A palatal exercise,
Yes.
yes. That is given in sleep apnea also.
Yes.
That exercise.
regarding your presby dysphagia,
Yes, sir.
earlier times before we had the VFS and before we had fees, what we used to do when elderly people came with dysphagia and endoscopy did not reveal any growth or anything, we used to send the patients for barium swallow X-ray under fluoroscopy, where we could when the radiologist said that there is tertiary contractions, then we used to say that okay, this is presby dysphagia, and that is how we used to reassure the patients that it is only
Yes.
related.
That too also I have done about on the fluoroscopy,
that
the
is there.
barium swallow.
Mm.
And patient taking barium swallow actually also he gets some relief also psychologically.
Maybe.
When he sees the X-ray that your barium is passing nicely, I think his neuromuscular contraction also becomes improved.
Yes. Willpower restored,
yes.
gets restored. And about that tertiary contraction, I think it's there in the literature about tertiary contractions in presby dysphagia when you find nothing clinically.
But this is a very unknowing subject. I thank Priyam that she has taken the subject because it is not known to many. Actually, not only our this ENT, but this we should consult with your speech language SLP like Pratismita. I have sent some autistic people, child to her also, and it is really good because the exercises Priyam also does, but they also do nicely, I think, because I found in the literature. I don't know which one gives him good result, but still, the agony of the patient is very important. They think like that.
So for the choice of subject, I have to thank counselor, because even I was not aware that this is a subject which can be pursued. So when he was sending me to Jayakumar sir, I was like, I don't know what one do subject. But once you go outside, the eyes get open, the mind get open, and then you see the scope of the subject. And I think gradually we are also trying to improve our skills and learning new things. First, we started with therapy. Now we are trying to move into the surgical options. So let's see how much far we can go ahead with.
Yes. We should be trained like that. Very good.
Actually,
Also
today I was attending that a neurology session where they discussed post-stroke dysphagia.
So you attended, no?
And silent aspiration. So they said sometimes, if you do surgical intervention is required to improve the aspiration or improve the voice. So phonosurgery, Dr. Nupur Kapoor Nerurkar was also there. She said that if you do phonosurgery, in many of the cases, it acts as a phagosurgery also. Like
No, that she has mentioned
yes.
actually that not only that your sleep surgery also improve.
Yes,
like a
yes.
phagosurgery.
Yes.
Phonosurgery. Therefore, in the morning, I told that I think it is a phonosurgery. But ultimately, I posted that phonosurgery improves with the phagosurgery.
Yes.
Also to add on that, Priyam had also already told about hyoidopexy. when we do total glossectomy, so in these cases we already know that although repairing with an anterolateral thigh flap is good enough to give a appreciable speech and swallowing, but still this patient aspirate in the initial phase of there. So when we do the surgery at that time also we can do that hyoidopexy, so that the laryngeal elevation is there and their post-operatively chances when they are going weaning into the feeding system, then the chances of aspiration is less. So these are the few, if we know the things that we have done this surgery and because of this surgery, these complications will have or these side effects will be there. So to improve that or to reduce the post-operative complications, we can do certain maneuvers or certain small things that can help us to gain a better quality of life later on post-surgery. Systemically, because of this concurrent chemoradiation, use of concurrent chemoradiation, these advanced stage cancers, and also this IMRT, IGRT technique have been started so as to reduce there is a term that has come up with known as DARS. This is dysphagia aspiration related structures. So these are the structures when they are completely radiated or when while doing surgery, these structures are removed, then the patients are more likely to have aspiration or dysphagia post-surgery or post-chemo radiation. So in IMRT or IGRT technique, they generally try to avoid give less dose, cannot be avoided, but giving less dose so that this complication doesn't arise. I think base of tongue, floor of the mouth, cricopharyngeal muscles, I think these are the structures, and few more structures are there also, I don't completely remember it, but these are the structures which are generally spared from IMRT or IGRT technique just as to prevent this dysphagia. So a lot of new things are coming up. Priyam, anything you want to add?
This just reminds me of another thing when doing a laryngeal surgery, be it total laryngectomy or open partial laryngectomy or near total laryngectomy, we do a cricopharyngeal myotomy, so that the spillover, especially in partial laryngectomies and near total laryngectomies, that laryngeal spillover should not occur. So we always used to do a cricopharyngeal myotomy for that. That is another indication for a cricopharyngeal myotomy.
Sir, any more question to Dr. Priyam?
Actually, I don't have a question. Priyam, I just wanted to say, like, I think we should also include a dietitian in our work, like when we are working.
Yeah,
after I heard the dietitian, that dysphagia talk, like it was actually very important for our team to work with a dietitian too. Like, because occupation therapists and physiotherapists are okay. Like for neurological cases, we need, and they're like, but then I think dietitian is like something we have to incorporate closely with our team. Maybe if possible, like when we start with from next month, maybe you can talk to our dietitian in Pratiksha.
Yes, that will be a good idea. Because I'm just giving the overview of the things to the patient, but the dietitian will have a better understanding. Like you said, the thickeners, that all these things, we have very little options, but they can give a better range of options to the patient, better practical options, in fact. So yes, that will be a good idea.
And also, very good news is that Nestle is opening, like they are making a thickener, so for the patient with dysphagia, so that we can suggest them. So they have.
I think we are having going to have a small meeting of dysphagia people in the next 2-3 months probably.
Yes, most probably. But they have just, I don't know when we are going to do it. They have just made a talk to me. Most probably in another 2 months or 3 months, we will do that. So hoping for it. So I would like to get everybody's support for that.
Yeah, of course.
Thank you.
Nowadays, the practices has been such that it's a multidisciplinary. Whatever subject you take or whatever small subspecialty of a super specialty it may be, But all this specialty needs multiple peoples, multiple collaborations, multiple helping hands are always welcoming, and we should try to incorporate as much as possible so that we can give best to our patients.
Mhm. Yes, there was a this thing in that neurology dysphagia earlier today. They had mentioned about the importance of the dietitian, because especially in elderly patients in whom silent aspiration used to occur normally sometimes. So the dietitian is important in that, so that they can formulate that kind of diet that the patient should be given, because a lot of elderly people, don't take adequate nutrition in their diet. So the dietitian can help formulate the kind of diet where the nutrition at least is maintained in these elderly patients.
It is mentioned in the book also that not
Ah.
only the maneuver and your surgery, but the type of the diet, semi-solid, liquid, or solid, according to the site of the dysphagia and the cause of dysphagia, it should be monitored. It's mentioned in the book very nicely.
Yes.
Because Pratiksha is right, because you should consult. Dietitian may not know actually, but you should be, but he or she should discuss with the concerned people also, because this cause and site of the dysphagia. Because in old days, dysphagia, that is actually small food, slowly, versus a spoon is a good, I think, because according to some advice we give, it works good, but slowly. But people are exaggerated, no? They will not take slowly, but you have to counsel them nicely. Then also they will take slowly. But they are very difficult to deal with also. Thank you, Priyam.
Thank you, sir.
Thank you. So we are coming to the end of the session. So thank you, Priyam, for your wonderful talk. And I'll also thank other members who have participated very nicely into the upcoming subject. So if no more questions, then I'll hand over the mic to Dr. Anjana, please.
Thank you, Dr. Priyan, for your lucid presentation. And thanks, Dr. Mahamaya Prasad Singh, for accepting our invitation and giving expert insight on the subject. And special thanks to Dr. Kudus Ahmed sir, and Dr. S.D. Fukan sir, and Dr. Gautam Khan sir. And last not the least, sincere thanks to all viewers who always encourage us. Good night.